Assalamu alaikum wa rahmatullahi wa barakatuh. My name is Laila Mohammed. I'm a fifth year medical student. And today, inshallah, we will talk about genetic and metabolic CNS diseases. First thing, I wish you pleasant Ramadan, inshallah. So let's start. The categories of inherited disorders in CNS, they are mitochondrial and channelopathy, whether they are from CNS or muscles. We have lysosomal, and because of amino acids, or metals such as Wilson disease. So mitochondria is the energy source of any cell because of the production of ATP. And this process takes place because of the respiratory chain, which is embedded in the inner membrane of the mitochondria. And if it fails, all organs will suffer because all organs take its energy from the mitochondria. The respiratory chain enzymes, they are unique because they have both mitochondrial and a nuclear genome. So the enzymes of the mitochondria will be unique because of that. And they are rich in mitochondrial DNA, which is a closed circular double-stranded molecule, and it only has 37 genes or proteins. Any pathophysiology for any mitochondria encephalopathy will take place because the capacity to produce ATP or energy and meet the oxidative demand of the cell will not be fully covered, so the cell will die by the end. The mitochondrial genetic diseases have unique characteristics. The first one is that it is depend on maternal inheritance. So what does that mean? It means that if there is only affected mother, she can affect her offspring, whether they are boys or girls. But if there is an affected son, he can't transmit the disease. So only women will, or daughters will transmit the disease. The second characteristic is something called polyplasmy. And so we know that in the cell we have multiple mitochondria, and inside those mitochondria we have multiple mitochondrial DNA, except in certain cells such as unfertilized eggs and platelets. Now the heteroplasmy is the third characteristic, and which means that we have so usually we have homoplasmy in the mitochondria, meaning that all the mitochondrial DNA is identical. But when we have mutant cell or mutant organelle, we will have both mutant and wild type genome, so normal and mutant. This takes us to what is called mitotic segregation. Mitotic segregation is mean when the cell or the mother cell is inherited to the daughter cell. It will have mutant mitochondrial DNA and normal DNA, but the percentage in which they are transmitted will be shifted. So for example, the mother can have a daughter with 0% mutant mitochondrial DNA, or 30% mutant DNA, 70%. So it will be different, which take us to the last characteristic, which is threshold effect. What is threshold effect? It means that the energy supply and the oxidative demand will determine for me how severely the organ will suffer. So if there is an organ, here's a question. Which organ will be mostly deteriorated due to mitochondrial diseases? Mostly the skeletal system will be affected because we have a high demand for oxygen and energy supply. So if there is a mitochondrial defect, it will affect mostly these organs and will lead to cell death as well. Okay, so this is a scheme for the mitochondrial DNA with its different parts, the heavy chain and guanosine and cytosine chain. These are examples for the mitochondrial diseases. So the first one, we have Leigh syndrome, we have the Sayers syndrome, MERF, MELAS, and liver's hereditary optic neuropathy. So for example, we have mutations in mitochondrial DNA in many of them, and the mitochondrial RNA, such as in Sayers and MERF as well. As you can see, for Kernes or Cranes, Sayer, if I pronounce it correctly, it is a sporadic disease. And now we will take each one in specific. Inshallah. Just 1 minute. So we have the Curran-Sayers syndrome, which has a sporadic nature, as we said, and it is a subset of a group of diseases that is called chronic progressive external ophthalmoplegia. It is a hereditary defect. For example, in Sayers syndrome, we will have bilateral symmetric ptosis. Symmetric mean in both eyes, and it's the same defect, which is a droopy eyelid. We will have pigmentary retinopathy, heart block, and ataxia and unbalanced gait. When you do muscle biopsy, we see ragged red fibers, which are the accumulation of mitochondrial DNA, the mutant one, below the sacrolemma and between the sacrolemma and the myofibers. Any questions so far? Okay, so for myoclonic ragged red fibers, or what's called MERF. MERF is a point mutation in the transfer RNA. Okay, so the voice is minute. Is the voice better now? Okay, so we have the myoclonic epilepsy with the ragged red fibers, or MERF. So it's a point mutation in the transfer RNA, and it could be mild and asymptomatic, or it could be severe and deadly. What is ragged red fibers? We talked about it in the Sayers syndrome. It's accumulation of mitochondria immediately beneath the sacrolemma and the myofibers. And this disease, which is MERF, is characterized by myoclonus, cerebral ataxia, and seizures. So they will have a jerky involuntary movement of the muscle with unbalanced gait and seizures. It may be associated as well with deafness, dementia, peripheral neuropathy, cervical lipoma, which is fat mass, or pyramidal signs, such also we have intolerance to exercise, short stature, lactic acidosis. So all of these features can be seen in MERF. Next, we have MELAS. It's also mitochondrial inherited disorder. It has a recurrent focal neurological deficit that resemble stroke. So stroke is an acute focal neurological deficit that happens due to infarction into the brain, either because of ischemia or hemorrhage. Here we have the focal neurological deficits, so we call it a stroke-like episode. They will have a transient hemiparesis, so part or half of their body will be weakened and in weakness. And this will be transient, and they will have a cortical blindness, and it can be combined with worsening migraines, headache, nausea, vomiting, and seizures as well. Usually, those patients have normal early development, but with time, they will develop these symptoms. So they will be normal for some time in their life, and then they will develop the stroke-like symptoms and episodes. Also, we will have red ragged fibers and lactic acidosis, fever, or infection could happen to those patients. And one of the treatments to give L-arginine supplement to treat the stroke episodes. Then we have the liver's hereditary optic neuropathy. The mutation will be in the mitochondrial DNA, which affect males more than females in early adulthood. It's maternally inherited, as we said, in all mitochondrial diseases. And you will have severe bilateral subacute loss of central vision, which will be sequential, which means that the first eye, or for example, the right eye will be affected than the other one. On fundoscopy, you will see peripapillary telangiectasia and pseudoedema and retinal ganglion cell death. The subacute necrotizing encephalopathy, or the Leigh syndrome, is the last mitochondrial disease we will discuss, and it's usually become apparent in the first year of life. It will lead to damage into the basal ganglia and the brainstem. And it has many symptoms such as hypotonia, deafness, failure to thrive, hypoglycemia, retinitis pigmentosa, they can't see well at night, lactic acidemia, and they will have 3-methyl glatonic aciduria. Okay, any questions so far? Okay, we have the trinucleotide repeat diseases, and one of them is Huntington disease, Fragile X, spinobulbar muscular dystrophy, or atrophy, Friedreich ataxia, myotonic dystrophy as well. So I borrowed the tables from the slides in the lecture. We have here Fragile X is a very unique and distinguished disorder that will lead to intellectual disability. So we will have the CGG repeated more than 200 times, and depending on how many times it is repeated. So for example, if it's 50 times, the intellectual disability will not be severe as if it's repeated for 200 times, for example. They will suffer also from epilepsy, attention deficit hyperactivity disorder, autistic-like features. And it is an X-linked dominant disease. We have Friedreich ataxia, which is an autosomal recessive disorder. They will have ataxia that is progressive, and dysarthria and depression as well. So they can't speak well, and they will have depressed mood. We have Huntington disease, which they will have chorea, dementia, and depression, myotonic dystrophy. So the repeats will be involved are CTG on chromosome 19. They will have also intellectual disability, psychiatric symptoms as well. But the main presentation is muscle weakness. And the spinobulbar muscular atrophy, it's an X-linked recessive. The CAG will be repeated more than 38 times, and they will have atrophy and weakness of the muscles. Now, coming to channelopathy, so ion channels into the nervous system is important to conduct electricity and the messages between the nerves. So channelopathy is when there is a defect in this channels. It could be because of CNS or muscular, as we said in the beginning. So one of them is the Dravet's epileptic encephalopathy. The gene affected will be SCN1A in 80% of the cases, and the chromosome affected will be 2q24.3. We will have more channelopathies, and for example, sodium channelopathies or calcium chloride channelopathy as well. We have metabolic lysosomal diseases such as Tay-Sachs disease, Gaucher, Niemann-Pick, or metachromatic leukodystrophy, Graves' disease. So the enzyme of the lysosome that will be deficient in Tay-Sachs, for example, is hexoaminidase A. Gaucher will have glucocerebrosidase deficiency. Niemann-Pick is a sphingomyelinase. Metachromatic leukodystrophy will have the aryl sulfatase A, and the Graves' disease will have galactocerebrosidase deficiency. And most of them, as you can see, is autosomal recessive. Now coming to each one is in specific. So Tay-Sachs and Niemann-Pick and most of them will happen in the first year of life. So Tay-Sachs will have the patient will suffer from progressive neurodegeneration. So they will have seizure, blindness, spasticity, and they may die before they reach 40 years. They will also have a choroid macula, as well as Niemann-Pick. And Niemann-Pick will, in addition, have ataxia, dementia, and hepatosplenomegaly, or enlargement of liver and spleen. Graves' disease have irritability, spasticity, and developmental delay in very early age. They will have vision loss and intellectual regression, and they will have macrophages accumulation in galactolipids or globoid cells. And this will lead or happen because of demyelination within the U fibers in the white matter. The U fibers usually are important because they are linking between different areas in the cortex and the white matter. So we have the metachromatic leukodystrophy. It's a rare autosomal recessive lysosomal storage disease that causes progressive demyelination of the central and peripheral nervous system. And the multiple sulfatase deficiency is the defect in this disease. So we will have sulfatides and mucopolysaccharides accumulating in the brain and the peripheral system. So this picture shows the different treatments for different presentation in this disease. So almost all the systems, every system will be affected by this disease. So you will have bladder incontinence, you will have constipation, you will have swallowing problem, you may have polyps or cancer into the gallbladder, scoliosis. So many presentations in patients with the metachromatic leukodystrophy will occur, and this is the management of each one. To continue with metabolic lysosomal diseases, we have more of them. We have the Fabry disease, we have the mucopolysaccharidosis such as Hurler or Hunter disease, we have cyanosis, we have neurosteroid lipofusions, we have the X-linked adrenoleukodystrophy, and there are more metabolic lysosomal diseases. One of them is the cyanosis. So cyanosis is an autosomal recessive disease resulting from mutation in NEU1 gene, and it is characterized by the N-acetyl neuraminidase deficiency in the leukocytes. I think I forgot to try. Okay, so we have the fundoscopic exam will be cherry spot myoclonus in extremity. They are a hallmark for this disease, and we will see no excretion of glycose aminoglycans. So it looks like Hurler, but with no glucose aminoglycans excretion, which is present in Hurler syndrome. So moreover, we have the metabolic lysosomal glycogen storage disease, such as bombay and McLaren disease. So the enzyme will be deficient is in bombay, they are alpha-1 4-glucosidase or acid maltase, and they will have hypotonia, cardiomegaly, and they will have a high CK, and they will have limbic myopathy. So it's kind of myopathy, and the mode of transmission is an autosomal recessive. The chromosome, the mutation will be in chromosome 17q25.3. So I borrowed this table from the lecture, and you can see that McLeod will have a deficiency in myphosphorylase, and the clinical features will be fatigability, weakness, exercise intolerance, and cramping. It's also autosomal recessive, and the chromosome affected will be 11q13.1. So I believe this all you need to know about lysosomal diseases. So if you have any questions so far, please ask. So there is a question, is bombay related to liver? Actually, I don't know, but 1 minute, I may search it. I will search, so if I have an explanation, I can add it. 1 minute. Yes, it usually affects the muscles, and it affects the liver as well. According to WebMed, yes, it affected mostly. Yani, it will affect the muscles, the heart, and the liver. Okay. So we have metabolic amino acids diseases such as phenylketonuria, Mabel Syrup urine disease, and butyric aciduria and homocystinuria. So phenylketonuria, usually phenylalanine is an essential amino acid, which means that our body needed for better development, but we don't synthesize it in our bodies, so we should obtain it from food. So when we eat any source of protein, we will get phenylketonuria. And then in our body, the phenylalanine will be degraded to tyrosine via the phenylalanine hydroxylase. Now, if we have deficiency in this enzyme, we will have accumulation of phenylalanine, and this will lead to a certain or phenylketonuria, and these symptoms will happen to you, which are the patient may suffer from learning disabilities and brain and nervous system damage. They will have, in general, fair skin and hair and eyes. They will have eczema and jerky movement in arm and legs, so epilepsy or seizures, and tremors as well. And a musty smell to the breath, to the skin, and to urine. And the treatment will be usually by diet. You can give also medications to treat phenylketonuria. The second one is Mabel Syrup urine disease. And this disease is characteristic by the smell of its urine, which is like maple syrup or sweet smelling urine. And there will be accumulation because of the abnormal breakdown of the lysine and isoleucine and the valine. And the symptoms of this disease occur in early life as well. They will be sweet smelling urine and poor feeding or failure to thrive or loss of appetite, weight loss. They will have what is known as metabolic crisis. So they will have symptoms such as lack of energy, vomiting, irritability, and breathing difficulties. The glutaric aciduria as well, they will have or be unable to break down lysine, hydroxylysine, and tryptophan because of GA1 deficiency. And all of these diseases will be diagnosed by the newborn blood spot screening. When the newborn is delivered, we will do a Helibrek test to take some blood, and this is the newborn blood spot screening test. And the severity of glutaric aciduria, that it's mainly to floppiness and weakness in the muscles, hypotonia, or they will have also risk of intracranial hemorrhage, such as subdural hematoma, and they will have retinal hemorrhage as well. If they have metabolic crisis, they will have failure to thrive and the same thing, lack of energy, vomiting, irritability, and breathing difficulty, same as Mabel Syrup urine disease crisis. Then the homocysteinuria. This disease will be characteristic with the methionine, inability of the body to break down methionine, and the baby will have a subluxated, downward subluxated lens. They will have weak bones and osteoporosis. They will have vision abnormalities, as we said, subluxated or dislocated lens downward, and they will have bone and joint problems. They will have the risk to develop blood clot or stroke as well, and some children with untreated homocysteinuria will have even brain damage, and this will affect their development. Lastly, we have Wilson disease, which is an autosomal recessive disease caused by mutation of the ATP7B gene, which regulates copper transport from the hepatocytes to bile. So when it's defect, we will have accumulation of copper in all of our tissues almost, and we will have a Kaiser-Fleischer ring in the eye, movement disorders. There will be mood disorders, psychosis. Jaundice is one of the differentials for jaundice, the Wilson disease, or swelling of the abdomen, and tendency to bruising and prolonged bleeding will be one of the side effects of having Wilson disease. The treatment for it, D-penicillamine or tretinoin as well, will be treatments for Wilson disease. We have finished. So if you have any questions, please go ahead. And those are my resources. Okay, so if there is, okay.
Okay.
Yes, sure, I can share my my lecture. Inshallah.
Could you just give us some tips or general advice on what to focus
On what?
On what to focus on from the lecture?
Sorry, I didn't hear the question.
Could you just give us some general tips on what parts of the lecture to focus on?
Actually, I don't know how the exam will focus on what, but in general, you should know. Actually, I don't know, but you should know the unique thing about each disease, from features or a unique characteristic about.
Okay, thank you. So I'm going to stop the recording now.